So for NICU professionals, I think just being really aware of that oxygen level, that's huge. And finding that titration and going with the guidelines. It doesn't need to be 100%. That's not great. 95% is wonderful, especially if they're born premature and we're worried about retinopathy, prematurity. I think that oxygen status. I think also that the eyes are so confusing to a lot of parents. So any discussions, I mean, we typically will discuss always with the parents what's going on, but just reinforcing that what's going on, why do you need to see this other person? What are they doing? Just constantly, there are all those studies. You have to hear things like 7 times before it sinks in. And especially I would imagine for a NICU parent who is getting bombarded with
Yeah,
information
it's a lot.
constantly. And it's just one thing after another. I mean, just really just reviewing it one more time. All right, especially if it's something that requires treatment. And then just making sure that parents understand the importance of these. If there's a checkup recommended, why that's important.
Welcome to NICU Heroes, a podcast produced exclusively for NICU professionals, with me, Kathryn Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well trained to care for the tiniest and the sickest babies every day. While a NICU parent's scars are not as visible, those parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals, like you, better understand, support, and nurture the entire NICU family. Well, it's hard to believe that this is our last NICU Heroes podcast episode of 2025, but we're ending it really strong. Dr. Wong and I had the chance to visit over on our parent-facing podcast, which is NICU Babies Parent Support, and we were talking about ROP in infants. And at the end of that 25-minute interview, I still had a ridiculous amount of questions for her. And so I said, hey, I have this other podcast and it's longer and I have more questions. Let's do it again. And we did. And I think I mentioned this in our interview, but I think it's worth saying here is that I've loved finding a different organ or a different facet of the NICU life and diving really deep. Because when I get a chance to talk to that specialist, they're like, super fans and they know so much about it and it's so complex and so fascinating. So I'm hoping that as a NICU professional, you're loving listening to these as much as I'm enjoying asking questions of really knowledgeable, wise, and informative guests and specialists. It's tons of fun. So today we're going to dive into pediatric eye care. And so what are some things as a NICU professional that you should be looking out for? What are some things that you can be doing to be better advocates for your patient long term? What does that mean for their eye health? So there are lots of questions that I have for Dr. Wong, and I think that you're going to love this interview. I really enjoyed visiting with her, and I think that you'll enjoy listening. My guest today is Dr. Rupa Wong. She's an Ivy League trained, board certified pediatric ophthalmologist and the managing partner of Honolulu Eye Clinic. She's a dedicated clinician and educator, and she serves as a clinical associate professor at the University of Hawaii School of Medicine. She's also deeply involved in mentorship and advocacy, serving on the Foundation Advisory Board for AAPOS and the boards of Make-A-Wish Hawaii and Big Brothers Big Sisters Hawaii. She's been featured in Parents, NPR, Newsweek, Business Insider, CNN, and People. She shares expert insights on adult and pediatric eye health across multiple social media platforms. If you don't follow her, you should be. And she's a fantastic guest. And I know that you're going to love this very last episode of a really great year in NICU Heroes. So without any further ado, let's get to a really great conversation. Well, I'm excited to have Dr. Wong back on our parent podcast. You and I chatted about ROP, and then we had the chance to meet in real life. So now you're not just this person that exists on my screen. So I'm super excited that we get to have this conversation post-meeting in person. So Dr. Wong, thanks for being here.
Oh, thanks for having me. It was such a fun conversation the first time. And then when we actually got to meet in person for my podcast, that was really awesome. So I'm just happy to continue the conversation.
I know. I'll definitely link to our conversation that we had in back, when was that? Earlier this summer, right? May?
Yes, yes,
I'm
I know, the
I'm
time's flying.
It is. So it'll be good. It'll be good to have that conversation, particularly because you and I had a chance to really have a great conversation. So thanks for having me on your podcast. Well, I know that some people may know this, but I always think it's good for people to sort of get a background as to why medicine and why pediatric ophthalmology, because I think I'm just always fascinated why one particular part of the body is the part that you love the most and you want to spend a lot of years studying that. So I'd love for you to give people an idea of why those two things.
Sure. So I came from a family of doctors. My mom is a child psychiatrist, lots of aunts and uncles that were physicians and, coming as second generation Indian American immigrant, that's kind of the path was like medicine, go into medicine. And it was just something that really fulfilled my heart as well, which was amazing to find that. But I went into medical school thinking something totally different. I was not interested in ophthalmology or then even specializing in pediatric ophthalmology, but I knew I wanted to do anything in children, pediatrics. So I actually thought I would become a child psychiatrist like my mother, or I was really fascinated by pediatric oncology, which is so different than where I ended up. And in medical school, I realized I liked surgery. And then I really thought about, as I was exploring the different surgical fields, one of the first kids I babysat when I was 13, and now people don't do that anymore. Back when we were young, I think I
Right.
babysat kids. They were three siblings, and it was, I mean, it's crazy now that I think about it. It was 13, and the oldest was 4. And she was really nearsighted, had a lot of eye issues, had to wear a patch. She had amblyopia, and it just really interested me how you can make such a difference in a child's life so early on by just even simple things like glasses, as much as I love surgery, but even
Yeah.
that clinic aspect of just seeing patients in the office could just impact a child's life so much. And so that's really what drew me to the field. So after med school, I did my residency in ophthalmology, and then I did an extra year of fellowship training in pediatric ophthalmology and adult strabismus. And that's where I am now.
So was it the ability, I know you talked about that you kind of fell in love with kids first and then ophthalmology. Was it the ability to sort of intervene on the front end as opposed to seeing them as adults, or like what was the draw for children versus adults?
First of all, I think I have a lot more patience with children than I do with adults. So I
That's
knew
fair.
that was the population that I wanted to work with just in the beginning. And here's the other thing, because in the surgical subspecialties like ophthalmology or ENT or even dermatology, you do the training first, of course, in that specialty and then do extra training in pediatric. So there's a big shortage in these
Yeah.
specialties like pediatric ophthalmology. I think we only matched like 15 out of 65 open spots this past year. 90% of the counties in the
Wow.
United States don't even have one pediatric ophthalmologist. So it's this big need. And I thought, well, I love that patient population. And I love the combination of being able to truly impact a child's life. You can prevent blindness in a child by really
That's
simple
huge.
things. And it's so huge. So it was kind of the combination of both.
Well, now that you say that, I'm thinking where we live, there are not very many pediatric ophthalmologists. I remember it was really hard. Our son had to have a consult, and it was really hard, one, to find one. And then when we did, find time on her schedule. So if you're
Exactly.
listening to this, you should go into pediatric ophthalmology. So I think
Absolutely.
a lot of people who are listening to this particular podcast obviously have a connection to the NICU and dealing with kids who are medically fragile from the very beginning. So what do you think some things are, Dr. Wan, that they should be looking at or considering from the get-go? Like what's critical in the early days of the NICU that you're looking at from an ophthalmology standpoint that you think absolutely everyone who works with NICU babies should be looking for this?
Well, I think one of the biggest things, and there's been so much education, and I know the NICU professionals know this so well, but sometimes even for parents, it can be a little harder. And sometimes even for the nurses, it seems counterintuitive, but the oxygen levels that we give our NICU babies, because when you see the numbers, you want to feel like they are satting at 100%. And that can really impact the development of retinopathy prematurity in these preemie babies' eyes. So we have to really titrate that oxygen level and being very mindful of not giving too much oxygen because that can actually cause these abnormal blood vessels to grow. I think that's the biggest take home. And whenever we would do in services in our hospital, we'd see actually the ROP numbers drop. And then they'd start to pick back up. Okay, it's time to do another in-service, because it feels like, well, every baby should be satting at 100%. We should have the oxygen as high as possible. But when they did these studies, they found these higher oxygen saturations were not great for kiddos. And so we have to find that balance of giving them enough oxygen to survive and to do the things that their bodies need to do, but also to keep that retinopathy prematurity at bay.
Yeah, because your brain says, of course, we want babies satting as high as possible. And then
Yes,
you think, well, but now there's this other sort of thing that can happen if we do that all the time. I don't know. I think you and I talked about that on the last podcast. I remember finding that fascinating because your mind tells you we should be at 100, but then you don't realize that actually can do some damage to some babies. So, which babies does, like, is it a certain weight, Dr. Wong? Is it a certain age? Like, where's the cutoff for, like, if this baby's satting at 100, that's a good thing, but if they're doing it here, maybe we need to watch.
absolutely. So the criteria for me being called in to see a baby in the NICU is if they are less than 31 weeks gestational age. So even if they are 30 weeks and 6 days, then I'm getting called in. Pediatric ophthalmologist or a retina specialist is going to have to do an eye exam. Or if their birth weight is less than 1,500 grams, which is about 3.3 pounds. So
Yep.
if those two are happening, or one or the other of those two has happened for your child, then we have to start following them because they're more at risk for developing retinopathy prematurity. And then also sometimes the NICU attendings they call me in as well if the baby has some other medical complications. If they've, got a lot of oxygen because they've got some cardiac abnormalities, or, they've just had a really complicated medical course and they're really concerned, or they're very small for gestational age and they might not meet criteria. Sometimes they will call us in to double check because there's something that might put them at a little bit more increased risk, typically the oxygen.
Yeah, I think we were right on the bubble. We were just a touch over 3 pounds, so I think we got a first class ticket with one, and then we got the pass, and I was like, "Okay, so we can check that specialist off the list." But I do think that it sort of gives people an idea of what you're looking for. So, let's talk about that. Let's talk about the screening. So, when you do a screening, you're called in for a consult, whether the baby's age or their weight gives you an idea that this baby could be at risk. What are you looking for? How do you screen for that? I know you said sometimes it's a little scary if there's a parent in the room. Sometimes you're like, maybe you don't want to stay for this. So kind of give us an
Yeah.
idea of what that looks like.
So, that I think is just the number one. It can be so stressful for a parent to see. So
Yes.
first of all, our exams are super quick. So I always tell the parents, if you want to just step outside and grab a coffee, because typically most of us round in the morning. So we're coming in at like 7:30, 8, 9 a.m. Usually what happens first is that the nurses are going to give your baby dilating drops. So they're going to give the dilating drops about an hour before we get called in. That makes the pupil large so we can actually examine the retina. Typically, most places will have a nurse come in. So at my hospital, I actually have a NICU nurse that now just does retinopathy prematurity. She comes in with me. She swaddles the baby. She holds the baby. She's actually the one making sure the O2 levels are good, that the baby's heart rate is good, because the exam is very stimulating. What I do is I put a speculum in, so it holds the eyelids open. And then this is the part that can freak some parents out is I use a little metal instrument. It can either be a metal instrument called a speculum. It's very tiny, or even just a very skinny cotton swab, which is, a Q-tip, but on a metal end, but it's very flexible. And I use that to move the eyeball around when I'm examining with my indirect ophthalmoscope. So it's this big headset on my head, and then I use a special lens so that I can examine and magnify the inside of the retina. And if you go into the ophthalmologist as an adult, we tell you, look up and right, look to the right. And we get you to really look in all of the different directions of gaze so we can examine the periphery of the retina. Obviously, I can't do that with a baby. So we have to move the eyeball around so we can examine the periphery, because that's what we're really concerned about. When a baby is premature, their retinas have not fully developed. The retina actually doesn't fully develop in a baby until about 38 to 40 weeks gestational age. So all of these babies that are under 31 weeks gestational age, they're at risk because the blood vessels in the retina hasn't fully developed. So when we come in, we're examining, okay, what stage, what zone are those blood vessels at? And we're writing that down. And we usually have to follow them every 2 weeks. But that exam can be a little stimulating. Sometimes just the light makes them unhappy, makes them cry. Sometimes it can cause their heart rate to drop. So that's why it's really great to have a nurse I'm just focused on the eyes. The nurse is focused on the baby. And so she's with me at all times, making sure everything is good. Okay, take a break. Baby's getting a little touchy. And the actual NICU nurses that take care of the babies, they know this. So they'll say, okay, they get touchy when we do X, Y, or Z. So we walk in knowing what's happening. And typically tell the parents, listen, this exam takes me about 5 to 10 minutes. We'll come find you. The nurse will come talk to you about the results. So you don't need to be here for it, because to hear your baby cry is never a great thing. And to see us using this light and this little instrument, that can be really traumatic too for parents. But usually we do the first exam typically about 4 to 6 weeks after they're born. So we don't do it right when they're born at 31 weeks, because that's not when we see the spike in ROP. And to do an eye exam on a 30 weeker or 25 weeker or 27 weeker, that's going to be really traumatizing. So when they did the studies, they found there's actually this chart that we follow of what age the baby was born at, when do we do the first exam. And so the nurse puts it on my schedule according to that chart. So you might not see me for at least the first month. We give you a little break. And then after I see the baby for the first time, then I got to check every 2 weeks, typically, if there's something concerning, maybe even a little bit more closely monitoring for the follow-up. But every 2 weeks, until we can really check to make sure that the blood vessels have grown out all the way into the periphery and that it's considered mature. And then I don't have to see you for 6 months.
Well, I'm glad that you mentioned the timing of that, because I think sometimes when you're first admitted to the NICU, you know that you have all these tests and they're trying to assess, baseline for your baby. And then sometimes I think it feels like you might get 2 weeks, 3 weeks, 4 weeks down the road, and then a new specialist show up and you're like, why is this new specialist? Like, why weren't they here 4 weeks ago? So I think it's a good reminder that sometimes things can't be assessed at birth. You have to give them time before you can accurately assess and be like, okay, this is what we're really dealing with. And then also the knowing that it's all, I feel like the smallest test required the biggest pieces of equipment, which is a little freaking out, for the parent that's like, is this concerning? And I think that's when the NICU professionals are really helpful, because they can step in and be like, okay, so this is what's going to happen. This is what we're looking for. And this is how we're going to find the answer. So I think all those things are reassuring, at least from a parent perspective, but certainly as someone who's at the bedside working with those families, to say, this is what's happening, and this is why we're doing it. Like, this is why we have the thing that looks like a Q-tip to move the eyeball around. Like, when you said that, I was like, oh, well, that makes perfect sense. My kids don't listen to me at 16, so they're definitely not going to listen when they're that young. So you got to help them out. So I love that. So what do you think the biggest, like from an ophthalmologist perspective, what do you think the biggest barrier is for like a timely ROP diagnosis?
So I think that really most hospitals that are performing, I'd say almost all hospitals that are performing retinopathy prematurity exams, they have a protocol, which is great, because they've got you on the schedule. They've got a nurse that's going to coordinate those exams and those visits. I think the hardest part is once the baby's not in the NICU anymore. So if they're discharged maybe at 36 or 38 weeks because everything else is going well, that doesn't necessarily mean that I'm done with the eye exam. So then you have to bring the baby back for an eye exam, typically in the clinic. So I think that's kind of the biggest barrier. We've got a lot of social work that's really just case managers that make sure that people are just making all those appointments and coming to those appointments. But sometimes it's just hard. I know it's overwhelming. There's so many. There's nutrition, there's neo appointments, there's now adding a pediatric ophthalmology, right? There's so many different kinds of appointments. So again, at our hospital, we try to consolidate them. So even though my office is at the other hospital, when I come to do the NICU exams, the ROP exams, I do even those outpatient exams in the outpatient clinic of the hospital, which is where they're doing their neonatology and their nutrition. We try to like really combine them and bundle them and make them the same day, because we get, especially here in Hawaii, we get babies that are flying from the neighbor islands because they don't have a pediatric ophthalmologist over on those islands. So they actually have to fly with their baby, with oxygen tanks. And so we really want to make it as easy as possible. So, I mean, I don't want to, understate that burden. That's hard. That's really hard. But I'd say that's probably the biggest difficulty with scheduling, because when they're in the NICU, it's easy,
They're there. Yeah.
they're on the schedule. I go in, pop them in, pop in, I see them, I communicate with the team, the NICU team. So that's easier. I think the harder part is when they're discharged.
Yeah, I mean, we have some things here like a comprehensive care clinic, and I remember in the early days we would go and we would spend like 6 hours, but we would see all the people that we needed to see, which is really helpful. But I also think it's helpful to remind me and people that are listening that sometimes I think you look at that litany of like, these are all the appointments that I have to go to. And in your mind, maybe there's a heart murmur and it's causing them, some oxygen things. So that's something that you can see, like, hey, my baby's turning blue. So the cardiologist sort of moves up on the priority list. But when you look at their eyes, you're like, but they're tracking, they can see. Like, sometimes I think it might move down to the bottom of the priority list because you're trying to look for tangible signs when you're overwhelmed of which specialist is going to be the priority and which one can I put off.
Exactly. And I think that that's the hard part because it seems, oh, they seem to be fine. And there's other medical issues going on. They
Right.
might have a tube there. I mean, they might have short gut
Yes.
syndrome. So many different things that happen to our
Yeah.
little babies in the NICU. So I totally understand that it's one that we don't want to put off because we've seen if we can diagnose early retinopathy prematurity, if we can treat it either with the laser or the injection early, we can save the vision. Otherwise, we know that they can become blind from that if it's
Right.
untreated, if they develop. Not every preemie baby, and it's actually a very small percentage of the babies that have to be screened that actually develop retinopathy prematurity. But when you see one that does, that it's not, it's been untreated, well, that's the most terrible thing to see. It really
Right,
is.
because 'cause you're like, "That's preventable." So, what are some of the treatments and, like, in the last decade or so, like, what have you seen that's really changed, sort of exciting, or what are some things that are on the horizon for treatment of ROP?
So when I trained about 20 years ago in Boston, really the standard of care was laser. 30 or 35 years ago, it was a different kind. It was called cryotherapy, which is what they did. But then when I trained, it was laser treatment, which is still really, it's routinely done. And we do it a lot in our clinic, in our hospitals, depending on the type of ROP, what's the staging, how advanced is it, where is it located. And the laser really just looks like the same kind of headset that I use to examine the baby, the same lens, but I'm able to focus a laser beam into the periphery of the retina. And what that does is it stops the stimulation of the blood vessels because the blood vessels that are growing in retinopathy prematurity, they're abnormal. They're really fragile. They break and they leak and they can cause retinal detachments. And so if we see the retinopathy prematurity progressing to that stage, we want to prevent a retinal detachment. So if we laser the periphery of the retina, then we can prevent that stimulation that's going to continue to cause those abnormal blood vessels to flourish. So that's the treatment that we've typically done. But the ones that really has advanced probably in the last 15 years, it was just starting when I was training, is these injections. And it's actually anti-VEGF, so the vascular endothelial growth factor. It's the same type of injections if you have a parent or a grandparent, they might be getting for macular degeneration. And what that's doing is slowing the release of these growth factors that are promoting these abnormal blood vessels to grow. And the really nice thing about that is it's so easy. I mean, it's not without risk. None of these are without risk, but
Sure.
this can be done there in the NICU. When I do a laser, that takes about 2 to 3 hours. And I will do it
Wow.
in the operating room, which means we have to put the baby to sleep under general anesthesia. But these injections can just be done at the bedside where your baby is in the NICU at their bed. And
Wow.
they draw up the anti-VEGF and they can just inject it. I mean, again, nothing is without risk, but it really is a much easier way to treat it, but it's not for every single case. So if your baby is
Sure.
being recommended for laser treatment, there's a reason for it. You can please ask your ophthalmologist, okay, why are you recommending laser versus the anti-VEGF injection? And they will give you the explanation as to why. But that's a really exciting thing that's developed and has shown just wonderful promise in treating it. Now we have to follow those babies that get treated with the injection a little bit longer, meaning you've got to come in sometimes even
Right.
50 weeks, 52 weeks. So that we follow them a little longer because sometimes they can regress and we might need to do another treatment. But that's a pretty exciting thing that's happening.
As I'm thinking about that, I'm like, if I were a parent, I'd be like, I'm going to have to step out for the injection. I can't watch
Oh,
that.
100%.
You also have, there's so many, I don't think I realized it until I started visiting with specialties about all the different things that our organs can do, and then all the things that I think specialists screen for that are possible challenges or obstacles that people may have to go over. And I don't think I realized that the eye was so complex until one, I started following you, but then you find a new organ and you're like, "Ooh, what do I need to know about this?" So you love talking about myopia, which I think is fascinating because there's so many kids in the NICU that maybe are at a higher risk. So, first of all, let's define what it is, and then let's talk about some of the things that you do in your particular clinic of watching babies that may have had a rougher start and dealing with this particular issue.
So preemie babies in the NICU, they have a higher chance of developing myopia. Myopia is nearsightedness, and it's so confusing, the terminology, and everybody always gets confused. What does that mean? Nearsightedness is when you cannot see far away and you need glasses to see far away, but you can see up close fine. And if you wear glasses, if you look at your prescription, it's got a minus number. So that is myopia. So that is more associated with babies that are premature, but also now we're seeing just a huge increase in the number of kids who were born full term.
Probably because of these.
Yes, I mean that's really what we saw. I mean, with the pandemic and with just the way that kids are learning these days, the less time that they're spending outdoors, we're seeing they predict by 2050 half the world's population is going to be nearsighted, which is it's just a crazy, staggering
That's good
statistic.
business for you, but that also means
It's
that we have a lot of education to do.
we have a lot of education because there are things that we can be doing just to help as parents or as physicians, as clinicians, as healthcare workers to start to really slow that onset down. So this is one of the reasons that we have to see the preemie babies, the NICU babies for follow-up exams 6 months after, even if we're saying, okay, no, you don't have any retinopathy prematurity, I still want to see them at 6 months because there's a higher chance of them needing glasses. And so I still dilate their eyes in the clinic and I'm checking to see if there's any kind of refractive error, nearsightedness, farsightedness, or astigmatism. But the one we worry about typically, and especially if they've had some kind of laser treatment, it's associated with having a higher risk of nearsightedness. But there is so much that we can do. And so I really just want to educate about, because I think a lot of physicians, all our specialties and even just healthcare in general, sometimes we're so specialized, right? Like you said,
For sure.
but I don't know. I was talking with a nephrologist, kidney doctor, and they were mentioning, and this could be, and they gave an acronym, IU this, or IUSR. I was like, med school was 25 years ago for me. I
You're
do
like,
not.
what was that?
I am here, not down there. Okay, explain that to me again. So we get so hyper focused. So I think it's really, that's what I try to do online, is just to educate about some of the preventative strategies that everybody could be doing for their own kids as well as for their patients, and just to really offset these lifestyle changes that have happened in just the generation that's really contributing to that increase in nearsightedness. So one is getting our kids outdoors. And it seems so simple. And most of us like, oh yeah, of course. Can I tell you, Kathryn, I found this article. It was from 1930 I think it was the Journal of Pediatrics. It's like, I can send it to you. It's so fascinating. And it was talking about how to slow nearsightedness in kids. And it said, get some country fresh air, get outdoors more. They talked about low dose atropine, about the atropine eye drops, which get specially mixed and can be given every night to slow nearsightedness, to not study as much, that they noticed that it was related to doing all this reading. It's not just screens, reading, writing, all of that is considered near work, and that's linked to nearsightedness. But what do our kids do? They don't spend 15 hours on, reading a book. Right now they're scrolling on social media, they're on their computers, they're watching TV. These are things that have changed in just a generation. So trying to educate that we need to be more mindful, a little bit more intentional. Not that all screens are bad, but let's just be more intentional about how much we allow our kids because it could impact their vision later.
Well, yeah, and as I'm thinking about that, I'm thinking, okay, so if you have a preemie, there's risk factor number one, and now they're born into a world which they're all digital natives. So now they have two factors going against them, having been born early, and then now they're also in front of a screen, or maybe some of the therapies that they have are on screen. So I think that there's some real challenges there. I think I was telling my husband the other day, I said, I feel like we're even more hyper vigilant with our younger kids because I feel like some of the things that we dealt with our older ones are not the same as some of the stuff that we're dealing with the younger ones. So I know you spend a lot of time talking about myopia. Is it because is it the development that makes because the interruption of the development that makes them more prone to having myopia? Dr. Wrong?
Well,
Preemies?
I think it's something about with the oxygen levels. They don't exactly know. We know that for the lasers, that almost seems to be like a growth factor for the
Right.
elongation of the, because that's what is happening with myopia is mostly is that the eyeball is longer than the average eye. So then the light focuses in front of the retina instead of on the
Got it.
retina. So anything we can do, we don't want to like stop the growth of the eye, but to slow
Sure.
it because it's getting abnormally long, because that's what eventually causes not just needing glasses. Like, do I care if a child needs glasses? I mean, I care, but not that much. What I'm really trying to slow is if they get to a certain number in terms of how nearsighted they are, that means that their eye has been stretched thin. Their retina is getting, think of it like a balloon, and you're blowing up a balloon and then you inflate it a little bit more. It's the same material. That balloon material gets thinner, right? And not that
Yeah.
the eyeball is going to pop, but the retina is stretched more thin. So that predisposes to developing little tears or little holes or detachments of your retina, or even increases the chance of cataracts or glaucoma. And these are all vision threatening consequences of just
Right.
being nearsighted. So some people think, oh, well, it's fine. And again, on that laundry list of things that could happen with my kiddo, it's way down there. And I totally understand that. But if it's a very high myopia, that could theoretically cause blindness. And there are all of these statistics about if they're over a -6, it's increasing their risk of certain diseases of the eye up to 22 times, which is really problematic. So if there's anything we can do, just simple things like 1 to 2 hours a day of outdoor time, just getting your kids outdoors, even if it's indirect light, even if they're just walking, they don't need to be doing anything physical. But if they're just walking outdoors or from class to class, or, doing walking the dog in the afternoon, anything like that helps slow it. So they found in a lot of studies all across the world that that helps might even help prevent nearsightedness in kids. So that's just like one free, very simple thing. I know it's harder in the Northeast. It's pretty easy here in Hawaii to
Yeah,
do that.
not terrible in Hawaii.
Not too terrible. We could do that year round. But there are actually Facebook groups dedicated to this, and there are parents that are vigilant in the Northeast winters. They are getting their kiddos out and trying to make sure they get some of that outdoor time to get that dopamine release in the retina to really just slow that elongation of the eyeball.
Who would have thought that when I send my kids outside that I'm also like, "This is good for your eyes." Like, we know it's good for your heart, we know it's good for your mental health, but now I can also tell my kids, "It's also good for your eyes." Who would have thought? I
I
think
know,
I mean, it's interesting that that was in that journal and what you said that in the 1930s, and
30s.
that was 90. Am I dating myself? Yeah, that was 90 years ago, right?
Yes. I mean, it's like almost 100 years ago. It's crazy. It's coming full
Right.
circle. It's really interesting. In China, they actually did this study because there's so much nearsightedness over there, just I think because of the genetics and also because they study so much and there's like this huge emphasis on like education. They would lock the doors during lunchtime because all these kiddos would come in during lunch to study more. They'd lock the doors. They mandated you have to be out a certain number of hours during the school day. They made it a requirement. They saw their incidence of myopia just decrease drastically by like
Wow.
20%. It's pretty crazy. So they just started it as a public health initiative. And so it's really fascinating. And there's even one country, I might be wrong. I think it's Japan, but it might be China. Oh, I think it might be China, where they shut off the video games, the certain video games you cannot access past like 8 p.m. at night for kiddos, like the ones that the kids are doing. I thought that was like really interesting that they still like really just mandate, nope, no more near time. We're going to shut that off. And I mean, you can do that in a country like China.
This podcast is produced by Hand to Hold, a national nonprofit, but we're more than simply a podcast. Hand to Hold is here to support your NICU in two ways. One, you can refer your NICU parents to us for support, or two, you can bring dedicated Hand to Hold support to your NICU, either in person or virtually. Our support consists of one-to-one group and educational resources, including our family-focused podcast, NICU Babies Parent Support. For more information, visit handtohold.org and click on NICU Professionals. So is myopia something, so as you're thinking about a diagnosis of that, is that something that you can slow down? Is that something that you can reverse? Like, is that something that you can just pause? Like, give us an idea of what treatment does, and is it inevitable for everyone or just some people? Like, let's talk about that a little bit.
So those are great questions because there's now a lot of research about it. And before we didn't really know, but It's unfortunately not something you can reverse, but It's something we might be able to prevent or at least slow. So I've talked about this before. My husband is very nearsighted. I am just over 45 and in my reading glass, I'm 49. But I had my three kids, that side of their family is nearsighted, and they've had retinal detachments because of the nearsightedness. So that's the real concern. Again,
they're lucky that he married you.
That's right. So we can balance it. But when I was looking at my kid, I was like, all right, if I want to do whatever I can to even prevent it, not just slow it. So there is an eye drop. It's called low-dose atropine. It has to get specially mixed at a compounding pharmacy. So you can't just go to your local Walgreens or CVS and get it. It has to be written as a prescription and specially mixed, though there's some studies underway to get this as FDA approval. Right now, it's not FDA approved. But if you give that every night, now there have been studies that show it might even prevent nearsightedness. So my three kiddos actually are not nearsighted at all. They're 11, 13, and 16. They're still not nearsighted, not good. So that is something that's been shown to slow nearsightedness down. If your kids are already nearsighted and they're just, getting worse every year, which is the normal course because the eye is getting longer every year, this is an option. There are also these special contact lenses. They are in this country, in the US, they're called MiSight. And these are FDA approved to slow nearsightedness down. They kind of have these different rings of power. So they help the kids see for distance if they're already nearsighted, but then they have these rings that focus the light peripherally a little bit better than a pair of traditional glasses would. And that's been FDA approved for kids ages 8 to 12. So if your kid's already nearsighted, you can ask about these. They're daily disposable, meaning you throw them away at the end of the day. They're soft contact lenses. There are contact lenses that you sleep in as well. They're hard contact lenses. Those are called orthokeratology. Most pediatric ophthalmologists don't love those because we don't like to recommend to sleep in contact lenses. It increases risk of infection. It's actually changing the shape of the eye, but they do work. And if you're really closely monitored with an optometrist, that might be an avenue as well. That same thing that's been shown in studies to slow nearsighted, not prevent it, because you can't really start it as a preventative strategy, either of the contact lenses, but it slows it down. And then the other thing is there are special glasses not available in this country, but in Canada, Latin America, Asia, and Europe. So everywhere else except
everywhere else but here. Okay.
Everywhere else. And again, they've got these honeycomb patterns. So they're not like a traditional pair of glasses that we get here. And they similarly have been shown to slow nearsightedness down. So I do have some patients that will get them from other countries when they're traveling and bring them back. And that has been shown to slow it down. And then there's things we can do. Monitor the near work, the amount of near work that our kids are doing. And of course, they got to do their homework. They got to do reading. Yeah. So then what gives is, the social stuff, right? So I tell my kids, and especially, I think they're so scheduled. A lot of kids are scheduled. They're in athletics. My kids are on sports teams. There's not a lot of time during the week. So they know their gaming time for my middle son. He loves gaming with his friends. It's not like my kids are not on screens. My daughter is constantly texting her friends as well. So they're on screens, but we're just very mindful. We use a lot of apps to limit how much time they're on devices. And of course, the content. That's like a whole different
That's another podcast, Dr. Ron.
That's another podcast. I'm sure you got people that, like, I'm a big advocate of really monitoring that content.
Yeah.
And then getting them outdoors. So the getting them outdoors has been shown also, and those two things are free. They're hard. They're certainly not easy, the stuff that we have to do as parents, but they're a layer of protection.
I'm glad that you mentioned screen time because I know some people might be saying, oh, NICU babies are not on screens. However, their caregivers or their parents are on screens, and we know that our children tend to mimic what it is we do. So, as a parent is sitting in the neonatal intensive care unit and they're visiting with their doctors, their nurses, and their specialists, they're also communicating on their devices. And so, as I'm thinking about how do we help counsel parents to be good role models for their children. So when it comes to screen time, Dr. Wong, what are some things that you consider best practices? Because we know that the screens are not going away. So what do you consider some good best practices to sort of have in place so that as you're modeling good behavior for your neonate who is going to turn into a toddler and a preteen and all the rest, that they can develop good healthy habits too?
And here's the thing. I mean, there's so much data that's coming out, right? And so I know with my
And
first,
I think all of it's telling us what we already know, but now the
we
data is
already know
just confirming. Yeah. Yeah.
it's confirming it. And
Mm.
I want to preface this with, like, there's no shame or guilt with,
Yep.
and we've got to remove that, because sometimes you got to do what you've got to do. Like, you need to get
Sure.
dinner on the table. You've got to give your child, their iPad, or put something on the TV so that you can get things done. If there's not an extra caregiver to help out while you're doing that, a
Yes.
lot of us don't have that. So I think we've got to remove the shame and the guilt from the conversation about screens, because then otherwise it's really hard to enact change for our kids or in ourselves. So
Right.
if we can kind of treat it as like a neutral activity, and let's just look at what we can do, what we can control. But there's been studies that have shown, even if screens are on in the background, even if the kid is not facing the screen, it's impacting their neurologic development. They've done MRIs and they've shown, like, okay, they have decreased language processing if the caregiver is watching a screen. And mainly it's because then you're not interacting with your child. So I try to recommend, and this can be really hard, but I recommend the 3 C's, and I think this makes it a little bit easier. So content. If your child's actually actively watching, if they are like, 2 to 5 years old, the American Academy of Pediatrics and the American Association of Pediatric Ophthalmology and Strabismus say 1 hour of screen time for ages 2 to 5. So if they're watching screens, then you want to choose just high quality, very age appropriate type of programming. There's a lot of shows, like, I know people love Miss Rachel, or there's, stuff on PBS Kids, Educational Experts, Sesame Street, and those are great shows, but not under the age of 2. So that's kind of the first thing. They've actually said no screen time under 18 months unless it's just video chatting. And I think with video chatting, like FaceTiming, is fine,
Sure.
because there's a lot of give and take.
There's human interaction there. Yeah.
It's human interaction. It's not passive
Right.
consumption. So content is important. And then context. So as much as possible, we don't want to use it as a babysitter. But again, sometimes that has to happen. But if you can even be cooking and they are watching it on an iPad and you can hear it, ask, oh, they're watching something and it's got a sheep in it. What kind of sound does a sheep make? Oh, bah. You want to explain what's happening. You want to engage them in, like, kind of a real world connection to what they're watching. And that's going to just help, all the other aspects, not just the ocular and vision aspects, but the neurologic aspects. And then co-viewing. So if you can sit with them and watch what they're watching, that's going to be best. I like to say, if you can cast it, if it can be on a TV, that's going to be a little bit better for a child's eyes than watching it on a tablet or on a
Right.
phone. That's going to be better. So cast it over there. And also then it lets you, the way our setup is, I can see the TV from our kitchen. So I can then, if they're sitting on the couch, I know exactly what they're watching as well, which has that added element.
Cool.
But screens are tough. They're not going anywhere. And we want our kids to be digitally literate so that they actually grow up and know how to navigate these platforms and screens safely and, self-monitoring and not going off the deep end and watching, like, binging hours and hours because they've never had it their whole lives. But I think the 3 C's help. So content, context, and co-viewing.
I love that. Content, context, and co-viewing. I'm going to have to write that down, remind that to my husband. We're going to talk about that with our own kids. I love that. I want to go back to the development just a little bit of what are some normal developing signs that you should be seeing if your baby's eyes are healthy and developing normally? What are some milestones that you should see, like in that first 12 to 18 months before maybe you start to get concerned?
So, and this also depends on if your baby was born premature or not, because I think that's a big one. When they're born premature, that just like your neonatologist will tell you, all right, they're going to be a little bit. Exactly. We got to use the adjusted age. And then typically they catch up around age 2. So sometimes we can see some delay in their vision as well. And there's actually a diagnosis for it called delayed visual maturation. And so sometimes we don't see them meeting their visual milestones right when they should as well. And that's okay. That's normal too. So I don't want people to, hear me talk about some of these milestones and think, oh my gosh, my baby's not there yet. Like, that's like, what am I going to do? So I think that's very important just to start off with, because that's just, I don't want to like send anybody into a tailspin that, oh no, they're not doing this. But usually at about 3 to 4 months, your baby should really be starting to track. And they're not looking at things across the room. Their lives for the first year, they're right here, right? Because you're either like feeding them with a bottle or you're breastfeeding them. So this is their world right now. This is all they need. So they should be able to like see your face, and we should start to see them tracking as you are moving. At this point too, earlier than 3 to 4 months, you might notice your baby's eyes crossing, especially when they're looking at things up close. That's normal. But past the age of about 3 to 4 months, you really should not see that anymore. So if you're still seeing your baby's eyes crossing, then that's something that you want to be mindful of and ask your pediatrician about. And, at 6 weeks, totally normal. But past, 3 months, 4 months, 6 months, that's not something that we typically see. And again, it could just be delayed visual maturation, but it's something to see a pediatric ophthalmologist about. And then we start to see their vision just truly improve. When they're born, they're like almost 20/800, right? They're just seeing, it's not that they can't see colors, but everything is extremely muted, which is why you buy all those black and white graphic mobiles and the stuffed animals and the loveys, because that's what their eyes are really gravitating towards, those high contrast things. And then as they get older, their color vision starts to just get a lot finer. So by about a year, it's almost what it would be at an adult level. Really by 2, it really gets to that level. And every couple of months, their vision just gets better and better and better. So even by like age 1, say it's about 20 over, we can't check, right? We can't really put them in front of an eye chart.
Yeah.
We actually have these ways of checking even 1-year-olds. We use these stripes, little cards, and they're going to gravitate towards the cards with stripes. So there's ways to kind of check their vision, not by reading an eye chart, but it's called the preferential looking test. So when you go in, your doctor might do that. We don't necessarily do that for every single baby, but it is ones especially that we're concerned about. But we want them to really be tracking by about 3 to 4 months. We don't want their eyes to be crossing. And by, 9 months, a year, they're starting to get further and further out with their vision where they can see, and the world starts to extend. And it coincides with them exploring their world, right? When they're starting to crawl, when they're starting to walk, they obviously need to start to see over there. When they're young, their worlds are here. So that's all that they need.
That's such a great perspective that I don't think I've had anyone describe it quite that way, that the world is small. So your interaction with them and your face is such an interesting place for them to focus as they're starting to grow into their eyes. And then as their world gets bigger, their eyes get stronger and better and do all sorts of things. I had never thought about it that way. This is why I have you on the podcast. Okay, so if you leave the NICU, I'll ask this first question, then a follow-up. So, if you're leaving the NICU and you have not had a consult with an ophthalmologist and that has not been on your radar, what would their very first formal eye exam for your child, when should that be happening? And then the follow-up is that if you're a preemie, when should you be seeing your ophthalmologist?
Okay. So if the baby's been in the NICU, then they're just in general going to be a little bit more at risk and they're going to be on the radar. So usually the pediatrician might recommend, and the pediatrician is doing the baseline
Right.
screening for the eyes. They're checking the red reflex. They are actually even doing things like they're checking to make sure that they're fixing and following. And usually they're going to refer to a pediatric ophthalmologist if they see any red flags at any of those visits. You feel like you're always at the pediatrician's in the beginning.
It's
Even
true.
my babies were born term, and I felt like I was constantly there, like 1 week and 1 month, right?
This is why our pediatrician gets Christmas cards because we see them so often. Yes.
So often. And that's why when you go in, it's like lovely to
Yes,
see
all the cards. Yes, all the
all the
holiday
Christmas
cards.
cards on the, I do love that. But usually now, if it's a baby that like otherwise was just in the NICU and things wasn't on a ton of oxygen, they might not have their first eye exam until age 3. That might be normal if they pass everything with the pediatrician, and that's totally okay. It's different for a premature baby, and especially one that meets criteria for screening for retinopathy prematurity, because even if they don't have retinopathy prematurity, everything was normal with the retinas. We followed them all the way up to like 40 weeks gestational age. You still want to see us. The first exam would be at 6 months. And I always tell parents too, if there's ever a concern, you obviously can bring
Just
your
call.
kid in. If you're worried and you've got a preemie baby that wasn't seen by an ophthalmologist because they were born, like your kiddos, right at like 32 weeks, so they didn't need to see us, but you're still worried, come see us. We are happy to answer questions and just reassure, because there can be more eye crossing in premature babies. That's another thing that we double check, not just the need for glasses, but for strabismus, which is misalignment of the eyes. So there are these things that we're checking, and the pediatrician can check them. And I do always recommend that parents talk to the pediatrician first. We like to keep the pediatrician at the center of things so that they're coordinating all of these subspecialists, because they can synthesize all the information. But for a lot of us, I mean, we're happy to reassure. I saw a patient the other day. They came in because they were worried about, dad's eyes. Did the child inherit dad's eyes? Is there any
Yeah.
issue? And they told me, you can come once a year if you want, but honestly, the pediatrician's going to be following. Everything's fine. And they said, no, yeah, we don't need to add another visit if not needed to our plate. So I think that's where it really just depends on the medical history. The family history is so important. Is there family history of eye issues at a younger age, of needing to wear a patch, of wearing glasses before the age of 4? Those are all things of even cataracts. Babies can develop cataracts, and those tend to run in families too. So finding out that family history of eye cancers, that's a big one. And I have an episode coming up on my podcast about retinoblastoma, which is such an important one that we never want to miss in young babies and in toddlers. So it really does depend often on all of those other factors.
So, Dr. Wong, when it comes to maybe myths in pediatric eye health, like, is there one in particular that you're like, I really wish people didn't believe this because it's inaccurate when it comes to pediatric eye health?
I think one of them is that their kids will complain of blurred vision. If your kid
Oh,
is older, then yes, they might, but a lot of times they don't. And the reason is kids don't know what they're supposed to see. So
right.
I still remember my college roommate telling me, I never knew that leaves on a tree were supposed to look so defined. She just thought everything was supposed to look like a Monet painting. Like that was just what she thought the world looked like. So they don't necessarily come to you with saying, I can't see the board or this is blurred, because they're not sitting and comparing. with their friends. Oh, is this eye left eye? Is this? So really it's to make sure that you're seeing the pediatrician, that your pediatrician is checking the vision as they should. If there's concerns, if you feel like, oh, I don't know, they seem to be cheating, come see us. We're happy to do an eye exam. But I think that's a really big misconception, is that kids will complain that there's something going on. And oftentimes they really don't.
Yeah. For the most part, they're normally fairly happy in the sense that they don't know what they don't know, right? Like we're the ones that know all the bad stuff
Yes,
and they're the
exactly.
ones that don't. That makes sense. So, if you had to give NICU professionals like 3 key takeaways from about eye health or about ROP or even myopia, what would be like your 3 big takeaways that you're like, if you're in the NICU, these are the 3 things that I want you to keep in mind when it comes to monitoring your babies and their eye health?
So for NICU professionals, I think just being really aware of that oxygen level, that's huge. And finding that titration and going with the guidelines. It doesn't need to be 100%. That's not great.
Yeah.
95% is wonderful, especially if they're born premature and we're worried about retinopathy of prematurity. I think that oxygen status. I think also that the eyes are so confusing to a lot of parents. So any discussions, I mean, we typically we'll discuss always with the parents what's going on, but just reinforcing that what's going on. Why do you need to see this other person? What are they doing?
Yeah.
Just constantly, there are all those studies. You have to hear things like 7 times before it sinks in. And especially I would imagine for a NICU parent who is getting bombarded with
Yeah.
information
It's a lot.
constantly, and it's just one thing after another. I mean, just really just reviewing it one more time. All right, especially if it's something that requires treatment, and then just making sure that parents understand the importance of these. If there's a checkup recommended, why that's important, even if everything looks fine or seems fine with their baby's eyes. It can be, vision saving to make sure to see us even if they're just after they're discharged.
Those are good, by the way. Thank you for that. So, do you have any resources, articles, like organizations that you think are a good place to go if either a NICU professional or a parent's like, I want to know more about eye health? Like, what are some go-to places besides you, of course, that would be a good place for them to research and take a look at?
The American Association of Pediatric Ophthalmology, they have a whole for patients, for professionals section of their website with a lot of information about just eyes and vision, when's the right time to see, when do I need a comprehensive eye exam? Because this does differ than what optometrists, and I think there's a little bit of confusion sometimes too with what an optometrist is. So ophthalmologists are medical doctors. We go to medical school, we train in surgery, and then we fellowship train in pediatrics, and optometrists go, instead of medical school, they go to optometry school. So their recommendations are a little bit different than ours. So if you want to have the medical perspective from an ophthalmology, go to aapos.org. And there's a ton of information, resources there. And there's even a find a doctor section where you can type in your zip code. Like I mentioned, there's a shortage. And I know, especially like in places where you are, you might, in spots in Texas, people have to drive 2 or 3 hours to see a pediatric ophthalmologist. So if you need to find the closest one, you can enter your zip code and get a list of all of them that are fellowship trained like I am, so that you can, get the best, especially for things that are a little bit more complicated, really get the best advice. For glasses, for contact lenses, for myopia management, there are wonderful optometrists that do a fantastic job on that with things like glaucoma or cataracts or retinopathy, prematurity. Those you really want a pediatric ophthalmologist for.
I didn't ask you this, but what you just said made me think of it. So, what if you're at a hospital, Dr. Wong, that does not have a specialist that looks at ROP and maybe they're not fellowship trained in ophthalmology? Who's screening for that? And then if no one's there, should you schedule a follow-up visit with someone else once you're discharged?
So there's actually all of these guidelines to have certain levels of NICU. They have to have someone who does retinopathy of prematurity. So
Okay.
if you are giving birth at a smaller community hospital and your baby is premature, then usually they're going to be like in Hawaii, for example, if someone gives birth on Maui or Kauai, they actually get airlifted over to the big children's hospital here in Honolulu. And so that would be the case if there's a premature baby, that they're going to be sent from the smaller community hospital to the larger center with that level 1 NICU that has access to all of those resources for exactly that reason, whether for heart or gastrointestinal or for eyes, to be able to continue to monitor. So usually the team itself just takes care of that.
Yeah, I mean, I think sometimes we take things for granted we were at a large hospital, so literally any specialist that we needed was there, but that's not I mean, I've talked to, dozens of moms and dads and even specialists that are like, "My specialty doesn't exist in this particular area," or, "We
Yeah.
are very thin. There are not very many of us there," and so I can see that why that may be a concern both for the NICU professional who wants to make sure, like, are these babies getting the care that they need? And then from a parent perspective, like, what other specialists do I need to go hunt down to make sure that we're addressing all the things that could be a concern for our baby?
And hopefully the parent doesn't need to hunt them down themselves. I mean, really
Yes.
hope the case manager, the NICU
Right.
attending, the people that are on the team taking care of the baby really are coordinating that effort. I
Yep.
mean, I think this brings to mind, though, you don't know how many kiddos I've seen, babies I've seen in the NICU of baby moons. Parents that are like, okay, we're going to have a baby moon. We're going to Maui right before the baby is born, and they give birth prematurely, and they have to be airlifted to Oahu, and they are there then for 3 months. So that's something to just think about when you are planning baby moons to various places. Not saying don't come to
You know
Hawaii.
no, it's funny that you say that because after we had our preemie and then I got pregnant again with our 6th baby, I was like, "There will be no travel after a certain date because I know way too much, and we are
Yep.
staying near a hospital with a level 1 NICU." Like, I have learned my lesson, and so I think I'll always get a little bit anxious when someone's like, "I'm leaving and I'm 36 weeks." I'm like, "What are you doing? Don't do that." So, yes, I do
Yes.
think it gives us an idea of being smart about the care that you may get depending upon if you're traveling or not, making sure that you're near a hospital that can be helpful for your baby. I could ask you a million more questions, Dr. Wong, but I will wrap it up and just say thank you for being such a gift. I think what you share on social media is incredibly helpful for the layperson like me that doesn't have a background in medicine, but also for people who do have a background in medicine and they're looking for a good resource. I think there are doctors like you and other places that did not exist when my baby was born that were on social media, and now we have those resources. So when NICU professionals know, hey, I can direct them here, they have the receipts to prove it. They are excellent in medicine, but they also provide really good information. So thank you for the gift that you are, both in your hospital, but also for the larger community that follows you.
Well, thank you, Catherine. This has been just such a pleasure. And thank you for doing what you do. I mean, just bringing voice to the parents and the NICU professionals and just educating in the way that you do. I mean, that's so huge. I imagine that it really just helps decrease the stress and the trauma
I hope
associated
so.
with being a NICU parent. So thank you for
I
having
hope
me,
so. Yeah.
allowing me to.
No, I love it because I get to interview all sorts of really fun people and ask all the questions. So I'm the one that gets the best gig in the room. So I'll make sure that we share this in all the places. But Dr. Wong, thank you so much. Thanks, y'all, so much for listening. That was a fantastic conversation. I hope that you'll do me a favor. If you love today's episode, please share it with a friend. You can also review over on Apple Podcast or Spotify or wherever it is that you listen to podcasts. You can also give us a listen and a watch over on YouTube. It's how we reach more NICU professionals. Today's podcast episode is sponsored by Reckitt Mead Johnson, whose mission is to nourish the world's children for the best start in life. For more than a century, they have led the way in developing safe, high-quality, innovative nutrition products and continue to push the boundaries of nutritional knowledge with consistent, strong investments in scientific exploration.